Okay. I see that everyone is starting to log in, so we will get started in just a moment. But I would love to say welcome, everybody. We are so excited to have you join us today. This is going to be a wonderful webinar, and I do want to apologize that Eric is feeling under the weather today, but that's okay because we have Jesse who's joining us. And for those of you who have been watching our webinars for many years now, you will remember Jesse because he used to frequently speak on a lot of our nursing home abuse webinars, and a lot of them with Ingrid and with Eric. So we are just thrilled to have Jesse with us, and we do hope that Eric feels better soon. So he will be back to join us on some future webinars. But anyway, I want to go ahead and get started because we have a lot that we're going to be talking about today. And I do encourage everybody to ask questions. Be sure to put those in the Q&A box. Jesse will keep an eye on them, and then we will be able to answer them for you guys. And then later, I'm so happy because you're going to meet some of my amazing partners over at HMR, Fox AE, and OnPoint Legal Nurse Consulting. We love working with all of these companies, and I just can't wait for you to meet them. They're going to share a little bit about what they do and how they can help you and your clients. But for now, let's go ahead and get started. I'm going to go ahead and introduce our incredible moderator, Jesse, whose primary focus, he basically focuses exclusively on helping people who have been injured due to the negligence of others, with a special emphasis on nursing home neglect, civil rights litigation, as well as mass tort. He is also a graduate of the University of Georgia School of Law in 2007, and he gained a lot of experience representing government entities as well as insurance companies before he switched over to the good side about a decade ago. So he lives in Atlanta with his wife and his 2 children, and he's currently learning how to play the guitar with a little bit of success. Is that right, Jesse?
Very limited success.
Don't worry, because practice does make perfect. Yep. So anyway, guys, we are so excited to have Jesse with us, and he will be introducing Ingrid. I hope you have a wonderful webinar. Be sure to ask questions and let us know if you need anything. So Jesse and Ingrid, I'm going to go ahead and hand it over to you.
Okay, thank you. And Eric's under the weather, and I am a little under the weather too, just less so than Eric. So I apologize for my voice, but just wanted to introduce Ingrid. She's been a nurse for 40 years. We've worked with her before as an expert, and she's practiced in critical care for 10 years and then went on to get her master's degree in gerontological nursing, became a clinical nurse specialist. Since then, she's practiced in home care, case management, education in various schools of nursing, as well in clinical settings and wound care. And she went on to become director of education and research, and then the chief nursing officer at a PACE site owned by the University of Penn School of Nursing. She's been reviewing cases related to nursing home issues as well, and with pain and suffering, and reviews medical records and helps attorneys out in a lot of different ways. And she's been with Mindy Cohen at OnPoint since 2000 and came on as a full-time program director for long-term care at OnPoint in December of 2016. And I've heard her speak before, and she always offers a lot of insight. So I look forward to hearing from her today.
Thank you. Ginger, you can bring up the PowerPoint. I'm very passionate. For those that have seen me before, know that I'm very passionate about caring for older adults. And one of my main points always is that the people that are caring for older adults often are not experts in it, are not well educated in it, don't understand it, and it leads to bad outcomes. I think that most people that work in long-term care facilities and SNFs and assisted living are basically good people, but I think that they are not well prepared. It's sort of like would you want a pediatrician taking care of you as an adult? In medical schools and nursing schools, there's often just not enough education. There's whole pediatric sections that they're taught, OB/GYN and surgery and all that, but geriatrics is sort of the forgotten specialty. I have always loved taking care of older adults. It was very easy for me to decide to go into gerontological care, and the difference between when I use geriatrics versus gerontology, it's sort of geriatrics is the medicine of getting old, and gerontology is how getting old affects the body, and nurses are the experts with that. So I guess I'm also pushing for all of you that have in-house nurses that do merit screens for you to understand that looking at a case involving an older adult is different than looking at the care of middle-aged adults or young adults. We say that you're an older adult when you're 65 or older. So come May, I'm going to be an older adult. But certainly aging is different in every person. And oftentimes we do hear that aging is just the number. And I believe that that's true. But so I'm going to be focusing on what's considered normal aging and what is not normal. And also, the typical problems we see in long-term care, abuse cases, chronic diseases that we see and how they're managed, and then talk about medications at the end. Welcome questions as we go along. Jesse will shoot them to me as they come. So, okay. Next slide. So I never said I wanted to be old. I think I would have remembered not agreeing to it. It's an interesting thing, I think, especially in this country, that ageism exists, that we really don't like being around old people, that we don't want to get old, but yet we do everything we can to extend our lives as long as possible without really understanding that if we're going to live as long as we want or can, that means we're going to get to be old. And with that comes some normal stuff and things to expect. So, okay. So what is aging? Well, it's progressive. We can't stop it. It's largely predictable. We've learned a whole lot about it over time. There's differences that exist between and within people. You know that you can look at people that are 65, 70, 85, 95, and they can look great or they can look older than their age. Oftentimes that's related to chronic diseases, right? And how well we take care of ourselves. If you have a long history of smoking, you're going to have more wrinkly skin, et cetera. Genes and environment, we're learning more and more affect the aging process, but it's not a disease. But it does tend to make us develop medical problems as we get older. They become more common, and I'll get into the statistics of that, but most older people have at least one chronic disease, okay? Why is it important? We're all getting older and life expectancies are increasing. In 2050, we're going to have 2 billion people over the age of 65, and we're not prepared for it at all. There's no miracle cure or fountain of youth. Many experiences or symptoms may be incorrectly attributed to getting old, such as, the lady that goes to the doctor and says, my right knee hurts. And the doctor says, well, that's, you're 85 years old. What do you expect? And she says, well, my left knee is 85 years old too, and it doesn't hurt. Pain is not a normal part of aging. Healthcare workers, including primary care providers, nurses, and ancillary staff, often don't know geriatric medicine and gerontology, how aging affects us, because there's all kinds of nuances. And that's why I believe in having a geriatric specialist reviewing your charts related to older adults and things that happen. Okay. What are these changes? Well, our rhythms change, sleep patterns change, body temperature changes. It typically goes down. So, for example, if you see a temperature of somebody that's older around, in the morning or middle of the day that's 99, that's probably actually a temperature, because typically as we get older, our normal temps are more like 96, 97. Hormones change up and down, especially I think in both men and women, but we know about menopause. The body becomes less dynamic. Hearing, blood pressure, heart rate all change. The body's reserves decrease. Okay. What can we expect? Okay. What can we expect? Cognitive changes. This is sort of what scares people a lot, I think. Do I have dementia because Alzheimer's because I can't find my keys? No, it's if you don't remember whether you have a car or not. That's the more scary sign. When patients come in to see their physicians, that's typically their number one concern. Your brain does have structural and functional changes, but dementia, of which there's many, many kinds, it's not just Alzheimer's, involves different things, not just a decrease in the white and gray matter, but more dangerous structural changes. Right, you can lose your keys all the time. Yes, yeah, right. Long-term memory and vocabulary should stay stable. That's why you'll find with people with dementia, it can be so interesting to talk to them, because they'll remember songs, every single word of a song. They'll remember things that happened to them as children or in their younger adults, but they don't remember what happened this morning. But typically, your long-term memory and vocabulary do stay stable. You can find words in dementia. A lot of times, one of that's, the things that we see is word finding difficulties. Your skills and ability to do things like math or writing papers shouldn't really change that much. Problem solving and processing peaks at age 30. Isn't that good to know? So it will maybe slow down a little bit. Certain memories of events, short-term memory, and ability to do complex tasks may start to slow down a little bit in your 60s. Not with me so far. Go ahead. Okay. It's totally normal to have some difficulty remembering a name or misplacing an item. It's not normal forgetting your family members' names and faces, getting lost in your neighborhood when you're driving or walking, repeating questions over and over again. My mother used to ask me all the time, where did these flowers come from when she developed Alzheimer's? Forgetting the function of items, like what does a pair of scissors do? What's this can opener for? Personality changes. Some people who were always sweet and dear, all of a sudden can curse out more, like a sailor, and others that were typically not so sweet become much more sweet. Hygiene and diet neglect are also problems. A lot of times with Alzheimer's dementia and other dementias, there's actually fear of water. So that may make it difficult and need to be care planned for how to get somebody in a shower. With my mother, I used to have to tell her that we were having a party. So she was willing to take a shower and change her clothes. Okay. So we all know that vision and hearing changes, and dry eyes very common. There are treatments for it, and it may make vision blurry. Cataracts will happen as we get older, which makes driving at night difficult. Halos over lights, blurry vision. Farsightedness begins, and that's when we start to need to wear glasses after the 40. But the thing with vision and hearing is that these two can make things like dementia or depression worse. It's clear that people that get to be hard of hearing, that don't get hearing aids or have people that know how to talk to them in a lower, louder voice will become more demented. Same with vision. It's important that these folks in facilities have somebody to make sure that they can hear what's going on, not lose their hearing aids over and over again. And if they do, get a hold of new one, and the same with glasses. Okay. High-pitched sound is difficult to hear, more difficult to hear people talking in a group. Not normal change in hearing loss in just one ear, sudden worsening in hearing, or overall poor hearing. Okay. Mouth and swallowing. Appetite does a lot of times decrease in older adults for a couple of reasons. One is that our gut slows down, but the other thing is that you lose taste and thirst receptors. And of course, the other thing is that many people have hypertension, heart failure, heart disease, and are told to go on a low sodium diet. Well, salt is what makes food taste good. We have developed a like for salt in our diets, and there's a reason for that. My neighbor is 94. She has some heart failure, and her appetite has gone way down. She always loved food, so took the cardiologist me many times to saying it's okay to add a little salt to your food. It's okay to have some cold cuts once in a while. It's not okay to eat processed food from a freezer or canned soup. That's the stuff that's really high in sodium. But find things that make food taste better. One of the scary things too is the loss of thirst receptors. When people have dementia or they're in a facility where they're not offered water a lot, not just by leaving a water pitcher on their table, but actually offering it to them, either because they can't pick it up or they're not interested because they're not thirsty. This is how people get dehydrated and develop UTIs. Also makes you more prone to other infections. Chewing and swallowing may become difficult. Really important in all our lives to take care of our teeth, because if you don't, it turns out that cavities and poor oral care can actually lead to things like pneumonia and heart disease. So you may need more help and care with chewing and swallowing. That's why you want to see in a nurse's assessment what's going on with their dentition, what's going on with dietary. Some people with no teeth can chew a steak, but some people may not be able to. Choking is not a normal thing to happen in older adults, and we certainly see a lot of choking cases happen because somebody's given the wrong tray, which is scary and unfortunate. Okay. We do slow down. Most common side effect of medication is an upset stomach. That's number one. So you may see people start on medication and then stop taking it because it's upsetting their stomach. Typically, they should be taught to know that a couple of days of upset stomach should pass. But if it doesn't, then of course you want to change the medication in an older person if it's making them throw up, have diarrhea, or not eat, because that's dangerous. Vitamins may not be absorbed as well as when you're younger. Constipation is very common. Constipation can lead to things like pain and discomfort, UTIs, because the urine stays in your bladder. You can't empty your bladder all the way because the bowel is partially blocking things. Incontinence is not a normal aging change. It happens in a lot of older people, more common in women than men because of having babies, et cetera, and changes in the pelvic floor. There's several kinds of incontinence, like urge or overflow. Urge meaning like if they touch water, they want to pee. Overflow, that if their bladder gets too full, it just sort of starts to empty. And once it starts, you can't stop it. There are treatments for incontinence. It is, and one of the things you want to look for in a chart with somebody with a UTI or with frequent UTIs or falls is a toileting program, and being assessed to see if a toileting program will help if they are suffer from incontinence of bowel or bladder. Are there times of the day that before meals, after meals, before going to bed, etc.? Okay. Heart health. Well, this is why so many people end up with heart attacks and congestive heart failure. Our blood vessels do stiffen with age, so the heart has to work a little harder. When that happens, high blood pressure becomes very common as we become older adults and should not be ignored. The numbers are always changing. It used to be high blood pressure was anything considered over 140 over 90. That number's gone down to being more like 120, 125 over 70 to 80. There's a lot of medications to treat them, but remember, medications all have side effects and interact. And it's more dangerous in older adults, and we'll get into that. So things like palpitations or chest pain, dizziness, loss of consciousness, none of these are normal things. And if they're happening in the residents that we're seeing and looking at their charts and not followed up on, not reported to the physician, that's a problem. All of these things can be related to things other than heart disease, like anxiety, or inner ear problems, or seizures. So need to be evaluated and treated. Okay. Kidney function does decrease over time. Again, incontinence is not a normal aging change. Various issues can be treated. Really very important to look for toileting programs in your review of charts that are falling. Oftentimes it's because they're trying to get to the bathroom. Or somebody's not answering the call light, very typical, because very few facilities have enough staff. Unfortunately for men, issues with your prostate can start around in your 30s. Issues related to prostate cancer, assessing it and diagnosing it are changing all the time. PSAs may not be that accurate or telling as we thought they had been. So always changing. It's another reason to have nurses and specialists as your experts or are doing merit screens, is because we have to stay constantly aware and up to date of what's changing in medicine, and it always is changing. We get newsletters, we get journals, we have to do continuing education, so we're up to date with changes in the medical world. Okay. Bones and muscles. Starting at age 30, again, muscle mass starts to go down. And the scary thing with older adults is, of course, when they go into a hospital. And what happens in a hospital? You're in bed, sometimes for days at a time before anybody gets you up again. In that very short period of time, muscle mass and wasting starts, and it's difficult to get it back. It's why so many people end up having to go to SNFs or skilled nursing facilities for rehab after they're hospitalized, because we're not we're not good in acute care of addressing the needs of older adults. They're starting in hospitals to have special niche units where the nurses are educated on caring for the elderly, including getting them out of bed, dealing with delirium, that's such a common problem, getting them up and moving as early as possible, keeping folks hydrated, doing assessments related to and knowledge about older bodies. Stamina can decrease. Of course, we're all different, and that's why it's so important to keep exercising. There's just an article out today, big research study was done of meta-analysis that they've been saying 10,000 steps is the magic number, and now it seems it probably is more like, depending on your age, for people 65 and older, more like 8,000 steps, but always changing. Bone mass and strength decreases, but aging does not mean osteoporosis. It's not a normal aging change. And there are ways to keep it from happening. It's more common in people of Nordic heritage, Northern European, than, for example, African Americans, and that all goes back to sun exposure over the hundreds and hundreds of years. Vitamin D is called the sunshine vitamin because it helps us absorb calcium, but it also only comes out when we're exposed to sunlight. The incidence of sunscreen has made osteoporosis much more prevalent than it used to be because it keeps our vitamin D from being absorbed. But a broken bone also may be, the sign of an underlying process, like severe osteopenia or osteoporosis. People will end up with broken bones being turned in bed if they've got a severe enough case of osteopenia and osteoporosis. Okay. Skin does become more thin and more delicate. Bruising may occur earlier. That's why it can look so horrendous when somebody falls face first and you see them for days and weeks looking like they were hit by a train. Fat stores decrease, and there's inevitably some wrinkles and sags, no matter how much and how expensive your lotion is. And nerve endings in the skin become less sensitive, and you sweat less. And when all of these things can affect body temperature as well. So isn't this fun to listen to all the things that happen to our bodies? But again, the changes are different in every person, depending on lifestyle, how well people take care of themselves. Genes certainly affect things, the environment. Okay. The immune system does weaken. That's one of the issues with people getting infections, especially UTIs, sepsis happening rather quickly. The sequela, of going downhill from an infection happens much more quickly in an older adult. Red blood cells may decrease. Things like kidney disease will make anemia happen. Low iron, folate, vitamin D, B12 are not expected. With normal aging, the immune system does become weaker. This continues to be a complex, poorly understood process. We know that the older you are, the more at risk you are for infection, the development of cancer, and making vaccinations less effective. There's no medication for this to really treat this, but exercise, healthy diet, stress reduction have shown to improve immunity. And a little vitamin C here and there doesn't hurt, and zinc. Okay. Mobility, overall energy level will decrease slightly, but hopefully not too much. It can be easier to get fatigued, especially if you have chronic disease like heart failure or anemia. Balance may worsen due to many things, whether it's your ears or your vestibular system, which may result in falls. And this is why, it's important with older adults that do have any balance issues to do exercises to make it better. And there are many of them, like doing what this gentleman here is doing, standing on one foot, doing some stretching and a little bit of deep knee bends, etc., to keep our bones and muscles strong. Chronic diseases like arthritis, lung and heart disease that make us short of breath. and diabetes, which may give you things like peripheral neuropathy, that your feet don't feel things the way that they did, or affecting your blood sugar that can make you weak, whether it's high or low. There's serious consequences to immobility. And like I just mentioned, in hospitals, it happens. You know, and in nursing homes, we see it in SNFs, skilled nursing, where so many people go after they're hospitalized. They're going there to get PT and OT. PT is to strengthen muscle groups and get people walking. OT is to help them perform activities of daily living, like getting dressed or being able to cook for themselves. It's important that it's ongoing. It's important that when somebody does have a fall, that the care plan is updated, that therapy is brought in to reevaluate them to see if there's something that they can do. So we'll get into falls in a little while. If there's any questions in the meantime, just shoot them our way. Okay. So now I'm going to talk about some of the common issues that can happen that you'll see in the charts of, you know, these nursing home related issues. You all know you'll see pressure injuries. Part of my job has been over the years to help educate families and now attorneys that the development of a pressure injury, what used to be called a bed sore or decubitus ulcer, or a pressure ulcer, is not always because of poor care. You will often see, you know, the family gets to all of a sudden see a pressure ulcer that's gone from a stage 1 to a 3 or 4 relatively quickly, and always assume that this was related to poor care. There's a lot of things that go into the development and deterioration of a pressure ulcer, and what you really want to see is that the standard of care was met. They are not unavoidable unless the standard of care is proven to be met. Even in people in hospice, not everybody gets a pressure ulcer, but Superman, you know, died of a pressure ulcer to his sacrum coccyx. We all know the risk is related to mobility, really increases with incontinence, especially bowel and bladder. The main reason that people, there's two main reasons that loved ones end up being put into nursing homes. One is bowel incontinence. Families can manage urinary incontinence, but bowel incontinence is difficult for people. And the other is wandering and behaviors that keep family members up at night, that they just can't keep up with it. Nutrition certainly plays a role, especially protein. Pain, if people don't want to move, can't move because it hurts too much. People are uncomfortable laying on their side, then that needs to be managed. If somebody's in pain and is uncomfortable laying on their left side or right side and being kept off their bottom, then that pain needs to be addressed, either with comfort measures or things like Tylenol. Diabetes certainly puts you at higher risk for development and deterioration of a wound because of blood sugars being so important. If they're elevated, your wounds can't heal. There's also changes to blood vessels, over time, that can make decreased blood flow to our skin. So that too affects things. Heart failure with decreased oxygenation and blood flow. You know, heart failure is a very common problem in the older adults that we'll look at. And dementia, if people don't understand when you're educating them about the need for nutrition and eating their protein or staying off their side or rooching around in their bed because of behaviors, that certainly puts people at more risk. So you want to see a well-done, consistent pressure risk assessment done. Sometimes you'll see, gee, today it's 12, and then all of a sudden it's 16, and then it's 8. And they're checking off things that either are not true, like they are incontinent, but they're checking off that they're not, or that their nutritional status is okay. When nutrition's going in and saying losing weight, they're not getting enough nutrition. So you want to see accuracy and consistency in risk evaluations. And then a care plan. If they are at risk, is there a care plan that says something more than help turn and reposition? And monitor skin every week. I mean, that a care plan saying monitor skin every week doesn't mean anything, because that's the standard of care with every patient or resident. Falls, the other thing that, of course, we see in these nursing home cases is falls. A great colleague that likes to say things like they were on the floor more than they were upright. I just reviewed a case that involved somebody falling in about 2 months' time, about 12 times, and never had an injury until finally the last fall, when they broke their hip, and the sequela was that then they went downhill and died. But I said to the attorney that it was a weak case because they did everything they could have and should have done. Falls will happen. The goal used to be to prevent falls. Now it's to prevent falls with serious injuries. Things like fall mats, low beds, frequent checking, moving somebody closer to the nurse's station. When you see a care plan that says call, bell, and reach with somebody with dementia, that's a sign of a non-individualized care plan. 2/3 of people of older adults that fall will fall again. There's actually a syndrome where part of this is because they're so afraid of falling that they stop getting up, they stop moving around, they take shuffling steps, and that's part of the reason that they do fall again. It's somewhat related to normal changes, like we talked about, with mobility and joint changes in joints, etc. But again, falls will happen, but you have to see that the standards of care were put in place, that there's a meeting by the team after a fall happens to see why it happened and how the care plan can be addressed. Every time there's a fall, you should see a new date on the care plan with some new intervention. I know that attorneys continue to get upset and angry when we talk about the fact that chair and bed alarms are considered a restraint, but that is what, that is the nature of research these days. But I also think that we need to get smart about developing chair or bed alarms that don't alarm so that patient is not bothered by it, but that some sort of beeper on a aide's body notifies them that somebody's starting to get out of bed. We can get creative with this, and I hope to see that happen. It's starting to happen. Okay.
Hey, Ingrid, is now a time we could take a quick break?
Perfect time.
Perfect. And I'm so excited because I want to bring in one of our amazing partners. I'm just going to stop my screen for a second. I'm bringing in Cody from Fox AE. And by the way, this has been so interesting just hearing you talk about all of this. I do know a lot of times, when somebody suffers like a fall, that's a lot of times where I've seen they go downhill after that. I'm dealing a lot with my own family where my grandmother on my mom's side, she's 88, and I see that her mobility is starting to get worse. She's not moving around as much, so she's not able to do as much. And so we got a lot of decisions we'll be having to make with her. But I look at my dad's side of my family and my aunt, I think she's 88, 84. She's like perfect health. You would think she's 40 years old. She's on a farm up in Minnesota, throwing hay bales around. So I need to ask her what her secrets were. But both of them were nurses, by the way. So they used to take care of a lot
Well,
of
they're doing a lot of
patients.
research that's showing that a lot of it has to do with people not being stressed out. Stress is bad for our bodies. It causes, inflammation, and, it's basically good diet. You don't have to exercise. If you're living on a farm, you get your exercise in other ways. Keeping active, keeping your mind active, having
Mhm.
friendships, having loving relationships, all of that stuff. So,
Oh,
yes, interesting.
absolutely. I agree.
Hi,
Um,
Cody.
So we are excited, guys, because our dear friend Cody is popping in, who we just saw a couple of days ago because we were all just in Miami for the National Trial Lawyers Convention. It was a great, great time. But Cody, we are thrilled to have you with us. I am so excited for you to share a little bit about what you guys do, what you specialize in. And again, I'm always blown away by your animations, graphics, but mostly you've got an amazing team that work with you. And every time I meet somebody, I'm blown away. So we're glad that you're here with us today.
Yeah, thanks, Ginger. Thank you, Ingrid. And I'm gonna kind of diverge away from the topic this time because we just got a $43 million whopper in New York. And you know what it was, Ginger and Ingrid, it was from a Connectionology connection. And so we got linked up with them and we did the graphics and it was a successful case. And I just wanted to show everybody kind of what we were working on and what the fruits of Connectionology were. And so I'm going to go ahead and see if I can get this up here. There we go. So we showed there was a police officer that was going 80 miles an hour speeding down and hit a woman right on the sidewalk. Didn't have his sirens on or anything. And so we show the mechanism of injury. And so she's paralyzed for life. But I just wanted to show, let me just rewind that just real quick. But we can show the mechanism of injury. So you see the C2 fracture, it actually caused paralysis. And so it put compression on the spinal cord. And then we also have collapsed lungs, and we can go through the entire injury as it occurs. And what's amazing about this is it really just makes it very, very clear and comprehensive of whose fault it is and the magnitude of the injuries. And so this was a big case, and really we owe a lot of thanks to Connectionology and all of our friends there, and everybody who supports us. So Ginger, Ingrid, you guys, with OnPoint and all of the sponsors, really HMR. It's just really great. It's almost like a little family that we've got. And so Ginger, thanks for doing everything that you're doing. It's amazing.
Oh, trust me, I am so excited for you guys, and congratulations. First of all, I'm stunned, but I am so happy. And wow, what an amazing result for your clients, you guys. Cody, that's incredible.
Yeah, thanks, guys. Thanks.
I
It's nice
encourage,
when you get to hear the outcome. A lot of times our attorneys can't share the money with us, but I know when they're satisfied. So
I'm blown
Right.
away. I'm like, I'm
Right.
seriously,
congratulations. That's wonderful.
you left me like
That poor
speechless.
woman though. Yikes.
I
Oh,
know.
it was that was pretty brutal. And so it's really nice to get that for the client. And it's also nice to win with these trial attorneys, with great trial attorneys. There's a camaraderie that will never die,
Mhm.
and
I see that in the nursing home attorneys groups that I work with. There is definitely a camaraderie. I'd say Jesse would say the same thing.
for sure, for sure. Ingrid, Ginger, guys, thank you so much.
On to the next.
All right, guys. And Cody, don't forget, put your information in the chat box. That way we can all stay in touch with you. And also just a reminder that after the webinar, I will be sharing a copy. Is it okay to share the slides with everyone too, Ingrid? As well as your contact information. So that way everyone will be able to stay in touch with you, all of our speakers and our partners today.
Anybody that wants the slide presentation can certainly have it, and my contact information is on the last slide. I'm
Absolutely.
happy to take phone calls. If you're sort of itchy to discuss a case, that's fine. We all are at OnPoint, happy to be called. Our cell phone numbers are on our emails. Because oftentimes somebody wants to discuss something and get an answer. And it's kind of
Oh,
what we're known for,
absolutely.
is to get you what you need fast and get you
And
what you
also,
want, and that you're happy with the outcome.
and at the end of this presentation, Ingrid, I'm also going to have you go into a little bit about what OnPoint does. I know John Romano, he raves about the pain and suffering reports that you guys do, but there's just a ton of things that you guys can offer and help out with. So we will get into that.
Thanks.
I'm going to go ahead and pull the slides back up. We're going to get into some more of the common issues. But everyone watching, feel free to ask questions if you have any. This is a great opportunity to ask Ingrid because she is such a great expert on this. Let's go ahead and get back to it. Just give me a minute. I'm going to pull it right back up.
Okay, next one. Dementia, this is a chronic illness. And there are many types. You used to think that there were like 3 types, like Alzheimer's and frontal lobe and Lewy body, but there are many types: vascular related, alcohol related. Alzheimer's is a very, very common one, and typically what PCPs will call a dementia type. If they do, other times you'll just see dementia. Many signs and symptoms behaviorally. Medications like Aricept are only semi-effective. If they're started early, they can help delay symptoms. What you want to see in your residents' charts is that the behavior management is ongoing, and monitoring of effects of whether it's medication or therapies, and approaching the resident in an appropriate way. You know, what we've learned a lot about dealing with people with dementia, it used to be reorient. That is not the case anymore, because that's only upsetting to people. Certainly if there's, you know, just a little bit of short-term memory issues going on, then it's appropriate. But if it's a diagnosis of dementia, you just go along with what they're doing. They're coming up with some beautiful plans in nursing homes for dementia units, where they're almost set up to look like a little village. If they want to go catch the bus, you say, okay, let's go, or we have to eat first and then we'll go catch the bus, whatever. But if somebody has a diagnosis of dementia, especially with behaviors, a lot of times people are just sweet and pleasantly confused. Other times there are sexual behaviors, there are aggressive behaviors, there are wandering behaviors. You need to see a care plan that shows an individualized approach to those issues. Certainly something very common that we see in older adults for many reasons, some of which I already discussed, is malnutrition. Can go from mild protein malnutrition to severe. Risk, again, related to some of those normal aging changes that we see. The other risk may be depression. Extremely common in older adults. I'll get into that momentarily. Food dislikes. Anybody ever taste any food in a nursing home, in a facility, when they go in? I know we've all heard the horror stories of the fact that there are some companies and nursing home owners that spend something like $1.50 per day on food per resident per day. The other issue, and I know some places are getting creative about this, I want all of you to think about being asleep in your as a resident in your bed, and somebody bringing in a tray at 6:30 or 7 a.m. I don't want to eat at 7 a.m. Or they need a little help with eating. We know there's not enough staff to help feed people, and if they do, they're in a rush. There's no sort of comfort and company with feeding people. And if people do need assistance, oftentimes they don't get it. It's scary, but it's true. A lot of people in their homes, in my opinion, and from what I've read, that are living in community actually die of malnutrition because all they do, because of depression, poverty, not having help, is eat toast and tea. But it's considered, you know, when they're found, it's just a normal death. Protein levels, not really true indicators anymore. So if you have your experts telling you their protein levels are low, there's a problem. It's really more related to signs and symptoms like muscle wasting, cachexia, cheeks sinking in, eyes sunken in, changes in skin. Certainly people that are at risk for skin breakdown or that break down, they do need increased protein. So again, you may need to see on a care plan that they're getting their family involved with bringing in things that they like. You know, if it's ice cream, if it's peanut butter, if it's, you know, they hate fish and they're being given fish, you know, 3 nights a week. You know, you need to get the nutritionist involved. You need to get the family involved and educate about the importance, especially of protein. Feeding tubes do not extend life at the end of life. Feeding tubes can extend life. It's some severe trauma and it's a younger person, but if you are at the end of life and the dying process has started, feeding tubes will not extend life. I say this every chance I get. When I do merit screens, a lot of times what I'm seeing is a family going after a facility because they don't understand their loved one is getting old and they are dying, that this is the normal progression of dementia. They will stop eating, they will stop chewing. That if you've got heart failure and you're hospitalized, every time you're hospitalized, it's like you go down another step. You're never going back up to where you were. Every CHF admission, you're going down the ladder towards something, and it is a disease that will kill. Heart failure is due to many different things. Like I mentioned, I will be getting into it, but when you start to look at your chart, you're going to see some very common diagnoses, and malnutrition and dementia are often listed right at the top. So you're already about to a bad start if you're getting a resident admitted who's malnourished. It can be difficult to overturn, but you need to see that attempts were made with the whole team involved. If you see the nutritionist noting that they're losing weight and poor intake, and you see the PCP or nurse practitioner come in and say no nutritional issues or no issues per nursing, there's a disconnect there in the team, and it's a sign of not such good care. I'm seeing Kevin Cox is asking, when do you know when the dying process has started? Well, it depends on the disease. With oftentimes, and it depends on ongoing assessments. If there's a sudden change, it's typically not that. But if there's a gradual change with people becoming less and less communicative, and it's not related to dehydration, or it's not related to an infection, if they're eating less because they don't have an appetite anymore and it's dementia related, if they're sort of not communicating and being in touch with people. It's a complicated process, but people that are taking care of older adults should sort of understand it, especially the PCPs. And the other thing is that they should be having, when I talk about these chronic illnesses, I can talk about this a little bit more, like end-stage kidney disease is a killer. Diabetes, in the end, even if they try to manage it, is destroying blood vessels. People will just slow down, become less communicative, eat less, not engage as much. There's a lot of signs and symptoms. They are pushing people away. They're ready to sort of turn it all off. My point is with this is that primary care providers and nurses should, from the beginning, with these people that have these chronic diseases, especially dementia or heart failure, or kidney disease, be just talking with them from the beginning about what the trajectory looks like and the changes they're going to see, and the fact that they're at increased risk for skin breakdown, they're at increased risk for malnutrition, and we're going to do our best to keep that from happening. But this might be part of the process of end of life. And what can happen then is palliative care, which is not hospice, which is where you're keeping people comfortable. But if something happens and they want to go back to the hospital, they can. But you start to take meds away, and you help the family and the resident, go through the process. Hospice is much more point on with stopping meds, with starting things like morphine. Morphine will not hasten death if it's given appropriately. As a matter of fact, it may prolong life a little bit longer because it helps people breathe more easily. It helps with shortness of breath, with keeping people comfortable. So your expert should be able to help you deem in the chart, look and see, was this the dying process? When did it start? What did they do about it? Common issues, more common issues, depression. I will get into mental illness in a little bit, but it's very frequently underdiagnosed, and symptoms may be atypical, like pain. I had a lady that I was seeing as a case manager nurse, and she had just moved from Atlanta to Philadelphia. She was coming to my exercise class. When I would see her, I could tell she was a very well-kept woman, a lovely Southern accent, and she said, since I've gotten to Philadelphia, my pain in my back is so bad. And I talked to her and found out she was very depressed and very lonely and missing her family. And I told her to talk to her PCP about it, who she liked very much, and she did. And she was put on an antidepressant, and her pain went away. But when we think about depression in older adults, and all of you probably are getting a little depressed just looking at this and all these changes that happen as we get older: loss of loved ones, loss of work and meaning in life, loss of friends, loss of independence, loss of dignity, loss of mobility, loss of home and having to move into a nursing home, loss of abilities to do things on their own, there's a lot of loss. So depression, although not a normal part of aging, does happen to a lot of people and needs to be addressed and talked about. Pain, not a normal aging change. And it is expected that people in these facilities determine the causes of pain, the factors that make it better or worse, assess levels, assess treatment, and reevaluate and reevaluate. You will see a lot of times that somebody's in pain. Is that causing non-compliance with things like turning? And that should it be addressed? And yes, you'll see that they were given, Tylenol, and it should be, you should really see numbers like 1 to 10. We don't usually, but you should certainly see whether it was effective or not. And if it was not effective, which I see a lot of times, follow up by the staff with the PCP to say, this is not effective. What else can we try? UTIs and infections, very common. Part of the UTI thing is changes in our immune system. Part of it may be constipation. Part of it is that we're not up and moving as much. Bacteria like moist, dark, still places. So if you're not moving as much and urine sitting in your bladder because you're maybe not emptying it all the way, or because you're dehydrated, you're prone to getting a UTI. And the sequela from a UTI or infection of the skin called cellulitis, or infection in your upper respiratory infection or in your lungs, to developing into sepsis can happen rather quickly. And that's when a lot of times we can help attorneys note whether everything was done or whether they ignored signs and symptoms, which are typically, with older adults, not necessarily a rise in white blood cell count, not necessarily a fever or temperature, but decrease in appetite, confusion, a fall, becoming less communicative, changes in mental status. A lot of times that's what you see in the ER notes sent to ER with change in mental status. Now, what you should also see with this population is that the nurses are actually, when that happens, taking their vital signs, which may be normal, but looking at their urine, especially like if they have a Foley. Funny how they get to the hospital, all of a sudden somebody's noting they have dark, cloudy urine, but the nurses didn't do it. Or that they have a bunch of urine in their bladder because they haven't peed in an entire shift. Or that the nurses haven't been noting, encouraging fluids, palpating their bladder. I've yet to see a nurse do that. So same thing with assessing for lung sounds. If somebody's coughing, you ought to see a nurse's note, an RN, not an LPN, noting that they've listened to their chest. And if they're coughing, is it dry? Is it moist? Is anything coming up? And always notification of the PCP and family with any changes. Okay. Can a UTI lead to an ischemic heart attack? Well, all of our systems are closely tied in. If the UTI gets to be severe enough and you have severe enough heart disease, yes, it can put a stress on your heart. An ischemic heart attack is just another way of saying a heart attack. An MI means myocardial ischemia. It means that lack of blood flow has caused death of a piece of the heart tissue. And that lack of blood flow is called ischemia. So with any MI or heart attack, there is ischemia, but it's prolonged. If you get to it fast enough and you get the blood vessel open, hopefully, with aspirin or getting in there and doing a stent, you can keep any muscle from dying or more muscle from dying. But yeah, a severe enough infection can lead to a heart attack. But again, you want an expert to look at that, to look at the timing and elevation in their enzymes and how bad was the UTI and when had it been treated, etc. But yeah. So common chronic conditions, chronic diseases in older adults. The problem with cholesterol and diabetes is that it's growing exponentially. Some doctors, when you look at websites, are saying, are we now obesity doctors? Because of the fact that Americans starting at a young age are eating lousy diets with processed food. Our babies and children are getting to be obese. They're not exercising. Their diets stink. And then as we get older, lack of mobility, lack of exercise, lack of education, lack of money, lack of caregivers leads to obesity, and which is a risk factor for the development of diabetes and the worsening of diabetes. Hypertension is also related to all of these things. There are medications for hypertension. There are medications for high cholesterol. Arthritis affects mobility. There's many kinds of arthritis. There's osteoarthritis, which is, bone on bone happening because the joint's wearing out. There's rheumatoid arthritis, which is more of an immune disease where your joints get red, inflamed, all of which is painful but treatable. Ischemic, like I said, lack of blood flow, coronary heart disease, also growing exponentially. I think that there are some people that would say that there's more than 27%, that ranges in these numbers are higher. That's what's shown on this chart. This was from Medicare and Medicaid, as you see below. Chronic kidney disease, I'll talk about that. Heart failure. Heart failure many times happens because of a heart attack, a significant piece of muscle dying so that the pump of the heart doesn't work as well because the muscle is not as effective, especially several heart attacks. Sometimes viruses can cause heart failure, but again, it's a disease with a trajectory that it will get worse over time. Alzheimer's disease and dementia, I think it's higher than this. And COPD, a lot of times from smoking or being exposed to toxins and chemicals. Okay. So kidney disease, as we get old, there are normal changes, but they're slow. Acute kidney injury is something we see a lot of times. AKI, that's typically related to a bout of severe dehydration where your BUN and creatinine go up, the kidney's damaged, but it can rebound. There's stages 1, 2, 5, 4, and 5 are end-stage renal disease, and that's when people need dialysis. There are some nursing facilities where they do dialysis within the facility. Most times they have to be sent out. Risks are related to it are, all the things that happen with older people: hypertension, diabetes, various medications, your cholesterol being elevated, heart disease, obesity, and genetics. You think about these folks that often are chronically ill appearing, have to be on special diets, get malnourished, don't feel well, and then they're transported to dialysis, then they're on a hard table or sitting up in a chair. And the folks that have wounds, sometimes you have to go after the dialysis unit as well for not making sure that they're somewhat offloaded with a cushion during transport and while sitting in a dialysis chair. Heart disease, again, some stiffening of our arteries does happen with the normal aging process. We can make it better through exercise, diet, and stress relief. I know many attorneys that have a lot of stress in their lives. I'm encouraging all of you to take good care of yourselves and do what's needed to relieve that. The rate of changes related to heart disease related to, very, very seriously to the amount of exercise. And now they're saying it does not have to be high intensity cardiovascular stuff, that walking is good. Diet, again, it's the processed food that we eat that's bad. Eating a lot of sugar doesn't give you diabetes. It can make diabetes worse if you have it, especially processed, refined foods. Palm oil is like taking the glaze of a glazed donut and smearing it inside your arteries. It is inside so many of the foods we eat. And one of the things I do is educate people to take a look at the paddle. Like Milano Pepperidge Farm cookies, the reason they taste so good is because of palm oil. It gives us food of mouthfeel, and it also gives food shelf life. It's a cheap way to manage our food sources, and it's terrible. And again, overall lifestyle, smoking, doing dangerous things. Now we've got raging drivers. Why has that gone up so much? That now, although the deaths and injury related to car accidents have gone way down, now it's way up because of all this rage. So Take your time with driving. Take a deep breath. Okay. Psych disorders. A couple issues here. One is that many times people with significant psych disorders end up in facilities because nobody can take care of them and because psych facilities close. And people in staff in nursing homes are, again, not trained in psychiatric care. It's a whole semester that you go through in nursing school and in med school. Bipolar disorder, schizophrenia, 20% of older adults have a psychiatric disorder. Only about 30% get any kind of treatment. Age-related losses, like I mentioned before, can be, need to be looked at and dealt with, whether it's with a chaplain or a social worker or some other counselor that comes in. I was going to say the chart I showed you showed less, but I'm going to say more like 33% of older adults have diabetes. Typically, it's type 2 that develops not as a child. Type 1, you always need insulin. It's because your body can't produce it. Type 2, it's that your insulin doesn't work appropriately. The scary thing with diabetes, and especially in older adults, is hypoglycemia. It's worse to get a sudden drop in your blood pressure in your blood glucose than to have an elevated blood glucose. Because if you have a drop in your blood glucose, it leads to things like encephalopathy, falling with injury. So people need to be closely monitored. A lot of times type 2 diabetics, hold on, I have to be right back. Larry, come, get the baby.
Hey, Ingrid, you can just unmute. There we go.
Okay.
Mhm.
So people with diabetes in nursing homes need to be monitored more closely than other folks. They are often not. If you get an infection, can it lead to a very high blood sugar level? Sometimes that's when people know that something's wrong and they're sent to the hospitals because their blood sugar is elevated. Not necessarily, again, their white blood cell count because of a muted immune response. Our white cell counts often don't change until way into an infection. Our vital signs may not change until way into an infection. Higher rates of death, disability, coronary artery disease, and stroke and muscle loss are all related to diabetes. So it's kind of a scary disease and growing exponentially as a problem in our country. Okay. So some of our older adults, if their blood sugars are not controlled, they may end up, besides taking oral hypoglycemics, need to be on either a daily dose of insulin or what's called a sliding scale. That if their blood sugar is from this range to this range, they get this many units of insulin. Higher, they get this many units of insulin. The last thing I'm going to talk about is medication issues. Is this a good time to take a break, Ginger?
Yeah, it sure is.
Okay.
In fact, I've got a couple more of our incredible partners that I would love to introduce. Let me hop back on. All right, I'm going to go ahead and find Laura from HMR. Let me bring her in real quick. Again, another amazing company that you guys we've been working with for many years now. Laura's going to come in and share all the great things that HMR does over their company. We were just with them in Miami too a couple of days ago, had a great time. And HMR is also one of our grand partners for our Nashville TBI seminar, which is coming up May 5th through the 7th. And all of that is about to launch. The agenda is incredible. There's like over 30 amazing speakers. I keep thinking each year, can we get better? And the answer is yes. It is going to be so much fun. Laura, I am so happy that you're with us. It's great to see you. If you don't mind, tell us a little bit more about what you guys do over at HMR.
Absolutely. It's good to see you all. If you don't know HMR servicing, just share a little bit of the highlights with you today on this very somber topic that we're all listening to. We are a nationwide funding resource. We work with you, attorneys just like you, nationwide in 39 states. We offer medical factoring funding. We offer cost of living, assistance to your clients. And then we also work with you directly to offer case cost funding. You know, two of the very first funding opportunities that I had with HMR servicing were with an attorney in Birmingham, Alabama. They involved nursing home care. They were tragic cases. One was a wrongful death, and one, a patient sustained an allergic reaction due to getting improper medication and had severe burn on her reaction on her body. So I share this with you just to let you know, and unfortunately, cases like this, everyone's rolling up their sleeves on the back end. That's where we shine, is in our underwriting process. We look at your case, we work with you to assess what it is that we can do to help you build your case up in a way that's going to benefit in either the family of the deceased or actually the plaintiff. So most of what we do nationwide is medical funding. We're fortunate to be a part of your patient or your client's recovery, getting better, getting those surgeries, getting that traumatic brain injury therapy, burn treatments, you name it, we are funding it. But also, as we're helping your plaintiff with their medical journey, we're looking at how do they maintain their life while they're getting better? Can we help them keep their house? Are we able to advance them their cost of living so that it's one less thing you have to worry about as well. But we're always working with you as a partner on your case. You are green lighting everything that we do. Once our underwriters have assessed what it is that we can do, we're coming back to you. We're sitting down, we're getting a plan. So I want to share that the best way to get started is go to our website, fill out your case, excuse me, fill out your case background. Let us determine what it is that we can do and start actively researching and underwriting your case in real time. We were just at National Trial Lawyers. We were lucky enough to have several of our team there in Miami. I know we had an after hours party. If you met someone from HMR Servicing and you're wondering what is the next step, how do I get in touch? Our website makes it super easy. We have an attorney portal at hmrservicing.com. That's always the first step. Our underwriting is free. We have a safe and secure portal that you can upload supporting documentation to. So we really do try to take the guesswork out and make it just as easy as we can for you. I'll put my information here in the text chat. And I invite you, if you have a question about a case, you don't know if we can get involved, send it over. We'll let you know quickly, and we'll reach back out to you. Thank you so much, Ginger.
Oh, absolutely. And again, you guys have heard me like a million times over. I rave about everybody that works on your team. Love working with you guys over there. So thank you for all that you do. I hope I see you on the road somewhere soon. And we appreciate you guys. And since I have you here, Laura, do you want to go ahead and ask Ingrid your question? Because this one's a good one about, and I hope I'm saying this correctly, Ingrid, can a UTI lead to?
Oh, yeah.
Yeah, do you like to ask her that?
So I think she saw it earlier.
Okay.
Thank you so much for answering that. And I'm sure everyone on the webinar today has a loved one. That was a question about my mother. So
Yeah, I'm sorry.
thank you. No, it's fine.
Yeah, all the systems they're all, as we know, I mean, our bodies are complex, but everything's connected and intertwined. And
yes, and I loved your mention about hearing loss because it's so closely related. I mean, it is the memory. If you're struggling to hear, and I know there's a lot of people are kind of ashamed to admit they need a hearing aid.
oh, absolutely. I just got one, not from being old. I actually had a tumor in my ear, but boy, it makes a difference because part of it is lack of stimulation. If you're not part of what's going on around you, you just go into your head more. That's why they say keeping our brains active, especially doing things like learning foreign languages as we get older,
Yes.
it helps. So hearing is definitely, it's a stimulator that keeps our brains active. It's also depressing not to be part of a group of depression. There's actually a pseudo dementia that's actually due to depression. You can look like you have dementia with significant enough depression. So that needs to be rolled out in people. It's all very complicated. That's why I'm such a proponent of educating people. It's a lot.
And this is why I was so happy that we were
Hope your
covering
mom's
this
okay.
topic.
Thank you. Thank you so much.
I was really happy that we covered this topic today too, Ingrid, just because I think we've done like it's over 300 different webinars now, but we had not touched base on this. And it's something that one, we're all going to have to go through, but two, there's somebody that we know who's going through this, but especially for all of our attorneys who are working with clients and taking on these type of cases. So you've been covering such a variety of different aspects of it, and I cannot tell you how much we appreciate it. But Laura, your mom's definitely going to be in our thought as well. And I tell you what, we're so happy to have you with us. I hope that you'll put your information in the chat box and everyone will save your information and call if they have any questions at all.
Thank you.
Thank you. All right, Ingrid, it's now a good time. I'll flip back over to the next slide. Okay. And again, keep the questions coming if you guys have any. I'm going to go ahead and upload it now.
Oh, sorry, before I'm a grandmother and I watch my grandson a couple of days a week, and my phone wasn't working to text my husband to come and get the baby. So sorry.
Oh, no worries at all.
3-hour nap. So sorry.
It's okay.
Keeps me young. Okay, so this also a very complicated issue. 1/3 of adults are dealing with polypharmacy, meaning 4 or more meds, typically related to chronic disease management, like one of the things we just mentioned. Dangers are related to normal aging changes because we have decreased body size. Our fat-water ratio has changed. We have more fat, so things get absorbed differently and passed out of our body differently. Liver and kidney function are decreased, so things stay around in our bodies for a longer amount of time. And then you have things like dementia, where you're not taking your medications correctly, depression, where you're not taking your medications correctly, finances, because you can't afford the medications. The other thing that happens a lot with older adults is that they're not honest with their primary care providers, whether they're taking their meds or not. They don't like taking medications. They don't like the way it makes them feel. They can't afford it. They don't understand it. They're not educated about what it does and what it doesn't do. And again, stomach issues are the #1 issue, may cause anorexia. If it causes things like diarrhea, that's a problem and it needs to be changed. But people need to be encouraged to be honest. I have done a lot of home care in my day where I found things like nitroglycerin in somebody's drawer. And I'm like, what, you're not prescribed this? Why do you have this? And they said, well, I get chest pain sometimes, so my neighbor gave it to me to take when I get chest pain. Education is really important. Nurses, the other, I think, unique thing about nurses and is we're educators. We're born to educate. It's part of what our expertise is and what's expected of us. It's part of what we're taught to do in school. So I'm sorry not to see nurses in doctors' offices anymore. I think it's affecting quality of care. Physicians don't have enough time, and a lot of times just are not good educators about disease processes and disease management and lifestyle management. So then I'm going to talk a little bit about black box. Next. Now they're just called box warnings. It started a few years ago as black box warnings. This is the FDA's warning system for dangerous consequences related to certain meds. You know, and every med, no med is perfectly safe. Every med has side effects, but some are much worse than others, and some are much worse than others in older adults because of those normal aging changes and because of chronic diseases. Best to stay away from non-steroidal anti-inflammatories like ibuprofen, Motrin, naproxen, because they're more commonly cause gastric ulcers. You will see many times in the long list of past medical history that you see in these charts include GERD. Everybody has GERD, gastroesophageal reflux disease, which means that the gastric acid is backing up into your esophagus and causing discomfort or even erosion or Barrett's esophagus. But our GI systems, with the way things slow down and thinning up mucous membranes, et cetera, it can make more prone to peptic to ulcerations in the GI system. Now, this doesn't mean that people can't take it if they're if they're good eaters and promise to take it with food and lots of water. It may be the only thing that's effective safely for some people, but again, it requires and warrants a warning. Benzodiazepines, bad. Antihistamines. The story goes like one time I went to see my mother and father. She had dementia. They were in their early 80s. I get there. My mom's wearing one slipper. She's still in her robe. She looks like a mess. I look at my father. I say, "What's the matter with her?" He says, "You tell me, you're the nurse." She has had chronic back pain from old thoracic fractures. So I sort of am thinking she does not look right. Her pupils are a little dilated. She looks dry. I say to my father, "Where's whatever you've been giving her for her pain?" And he tells me where to go, and I go, and it's acetaminophen PM, and the PM is in a little yellow thing that he couldn't even see, and the PM means that there's an antihistamine, Benadryl or diphenhydramine in it. It's a great drug for helping people sleep. It's a great drug for allergic reactions. Sometimes doctors will prescribe it to help people sleep, but it is a bad drug for older people. They cannot handle it. It messes up their nervous system, something terrible. So I got her into bed, and she slept for about 6 hours and got up and was fine. Sleeping pills that have these antihistamines and other sleeping pills are not typically safe for older adults. They increase the risk for falls and confusion. You'll see a lot of times in older adults that melatonin will be prescribed. That dose can really vary. It can go from 1 milligram to, up to 6 or 8. It should be monitored to see what works. That 1 or 2 or 3 may not work, and people may still be waking up. Antipsychotics like Seroquel, Zyprexa, and Risperdal in dementia-related psychotic behavior. Bad news, and I still see it being given, and it should not be given. So your experts should be looking for that. Okay. So in summary, I hope that what you're starting to see is that geriatrics and gerontology are specialties that need to be applied when caring for older adults, and I think also applied when you're getting your charts reviewed and getting experts on your case. Normal aging changes affect all realms of health, but they vary from individual to individual. Care providers must be able to differentiate between normal and not attribute to old age. That's called ageism, like the joke I told about the old person. We see a lot of neglect in our nursing homes. It's like, oh, they're old anyway. Jesse's colleague tells a good story about winning a lot of money for a lady that broke her arm in a nursing home, because what he did a good job of was showing how her life changed because of it. Her dignity was affected. To you, it may not seem like a big thing, but this is what happened to her in her life because of it. It was careless. A lot of times we don't care, in old people, it's not a part of our society that we're particularly good at taking care of. It's only going to get worse because the number of folks getting old is increasing, and the number of nurses and physicians treating is decreasing.
And Ingrid, it looks like we just got a question in, and I'll go ahead and read that. Treating the whole person's mind, body, and soul of geriatric patients and residents is key for good outcomes. It's important to listen to their stories, their values, cultures, beliefs, and their spirituality for a better quality of life. Care units seem to be understaffed. Do you see this happening? And if not, can this be added to their care plan?
Oh, absolutely. It should be. I think that just about everybody that enters a nursing home should have a problem of, well, they often do, new to facility, and there are nurses and social workers that are indeed supposed to go around and make sure that they're adapting to this change. But typically that's not happening anywhere in our healthcare system. So why would it be happening there? It is mind, body, spirit, and it should be part of people's care plans, especially if they're depressed or expressing loss or loneliness. lots of studies show that most older adults at one time or another do feel lonely. And I think that it's one thing is lack of education in staff, but the other thing is lack of staff. It's everywhere, and it's bad. And we all know that staffing numbers, we're starting to see Medicare and the government take it more seriously. Biden certainly understood that, or was educated enough to see that we have to increase staffing. But how do you do that? And just because you have more staff, if they're not educated and they don't care enough, then I don't know that that's necessarily going to mean anything. They have to be well paid. They have to be well educated so that they care about it and they know how. And so it means more to them. You know, mind, body, spirit in the people that take care of people is important too. And the people, you all know, the people at the top are making a lot of money to the detriment of the healthcare force taking care of these folks, and most importantly to the residents themselves. I mean, I've been reviewing charts now for 27 years now. I've been an expert for many of them, but I'm not clinically active now. But it's getting worse, and the stuff I see is just horrendous. And most of it, I think, is just it's lack of staff and lack of LPNs taking care of people when it should be RNs. Not that there's anything wrong with LPNs, but they don't have the education, the background to assess when an infection is serious enough that it needs to be reported to somebody.
Ingrid, there's one thing I wanted to mention about that too. Early on, we were talking about elderly residents typically have lower body temperatures, and it seems to me that a lot of times people will miss signs and symptoms of sepsis because they might have a fever, but it doesn't appear to be alarmingly high, but they're not taking into account the fact that they have a lower average body temperature. Is that something that you see?
Oh, for sure. What happens is that sometimes nothing is written for days before, and all of a sudden they're sent to the hospital for a change in mental status. Now, typically, it's not going to happen that fast. And what's going on is they're not being monitored closely enough. I mean, people need their eyes laid on in a total physical exam every day, and I would say by an RN who knows them. The other thing is that you have staff coming in from agencies and stuff that don't know people, so they don't necessarily see the subtle changes in somebody that usually talks all the time that isn't talking, or that usually likes to eat and they're not eating, or that fell down, they get up and no signs of serious injury, but this is new for them, and they, sort of putting the pieces together. Vital signs, again, may not change in somebody that's older until they're really into an infection. But typically there are other signs and symptoms that are showing up. And they do think that if they have a temp of 98.6, that if you look back at their previous temperatures at a certain time of day, if it was typically 96, then that is telling you something. And I would bet that most caregivers don't know that. Sepsis can happen quickly, but not that quickly. And most times there were signs and symptoms, and they just weren't picked up on. Or somebody the day before was acting weird, and then they say, but we gave them Tylenol, they're sleeping comfortably, and then they're not really having eyes laid on the total person until like 11 o'clock the next day. So.
Well, thank you very much. And Ginger, do we have, do you want to jump on, or do you want us to take one more question?
Oh yeah, if there's any more questions, you guys go ahead, bring them in.
I had a couple more things on that slide besides ageism, I think. Want to go back to that last slide?
Yeah, let me go back to that real quick. And then just a reminder, if you guys have any questions, now's a great time to go ahead and put them in for us.
Please, if something hits you later and you have a question, feel free to reach out to me. It's on this last. The one before that? Diagnose, and this is what we look for when we do merit screens, and what nurses or sometimes the attorneys themselves are looking. The documentation should reflect assessment, a diagnosis, coming up with what's wrong with them, not necessarily a medical one, but there's things called nursing diagnoses, treatment with whatever, whether it's pain or the wound or malnutrition, and then reevaluate, update the care plan in a timely and appropriate manner. So that's what your merit screen should be looking for. That's how you know if the standard of care was met or not. And then the last slide is me, my information. Feel free, happy to talk to anybody. If you don't know if you have a case or not. The other thing we can do for you is talk to the family and sort of get a feel for what's going on. I do that for one of my attorneys. We have the other part of our company has Dawn in charge, and she locates experts all over the country for non-geriatric related cases, surgeons, pathologists, therapists, whatever you need. She tries to get the total picture of what's going on. Many times she will help an attorney understand the type of expert they need, where they think they need a neurologist, but they should really have a neurosurgeon or a neuro-ophthalmologist. Very experienced, longtime nurse. And then the other branch of our program is consults. That's Lisa Mancuso, who's also president of AALCN. She has a lot of knowledge, a lot of also experience as a nurse to help you with crons and summaries and merit screens and for non-geriatric cases. And otherwise, I and my colleague Pat Stonich, who knows more about regulations than anybody, big time expert in assisted living. You'll see him talk at some of these presentations, nursing homes, home care, hospice. So we do it all, record organization and retrieval, pain and suffering reports. You know, one of the things that can work in some of your cases with, especially, you know, with these older adults, just because they're old, you know, the amount of suffering they went through is significant and shouldn't be happening at the end of their lives because of lousy care. That's my shtick, and I'm sticking to it.
Well, this has been absolutely incredible, Ingrid. You know that we love having you on here to speak.
Thank you.
in
I
this-
love teaching, but I do talk fast. I know that, but
No,
that's
this is
the other
great.
slides.
And we want to have you back because I know that there's more knowledge that we want you to share with everybody.
That's the other thing. If anybody out there has any ideas, between Patrick and I, we're always happy to present on whatever you want to hear about. I've done pressure. I've done infections and common problems in nursing homes, falls, and so I mean, if there's something you want to hear about, he or I are happy to do that with Connectionology, because we've certainly got good. Thank you, Bruce. We've certainly gotten good contacts through Connectionology. I know Patrick's going to be in Nashville, right? And have a chance to present to all of you and do a little song and dance, which we much appreciate it. So look for him.
I am very excited about it. And also for anyone watching, if you would like to rewatch this webinar or share it with any of your colleagues, we're going to be posting it to our Connectionology YouTube channel. If you go there, you can find out a couple of our other YouTubes and watch those as well. But before we head off, I am bringing in Ted real quick because you guys know what time it is. It is time to give away one lucky winner who's going to win 4 bags of freshly roasted coffee. The coffee that's been sweeping the nation, right, Ted?
It has been, yes.
Well, I tell you what, thank you for all that you do. And we're so happy that you're here with us today. If you don't mind, let us know who is the winner.
Yes, I just wanted to say I was happy to know that I live on a farm. I have 5 kids, so I don't think I'm going to have any problems anytime soon. Lots of exercise.
Depends if you have sons or daughters. What do you have?
I have a mix, three
Good.
sons, 2 daughters. So
All right, they'll take care of you when you get old. So that's very
more
good.
animals than I know what to do with. So good stuff. Let's see. So the big winner today is I think he's new to winning. It's Jeff Brody out of Kingston, New York. So congratulations.
Congratulations.
With this many webinars, we have a lot of past winners winning. So that's fantastic. It was a new name. So
Absolutely. Thank you. We're so excited, Jeff, for winning. And Ted, you and I can both reach out to him after this webinar. But love new winners, and we love a lot of our viewers have been watching for many years now, but we love when there's somebody new who's popped in on here. And again, like Ingrid said, if you guys have any topics, if there's any other speakers you want to recommend, just let me know so we can get that going. But Ted, thank you so much for doing all of this for us. And day in, day out, you are amazing to work with. And thank you for all that you do.
We love being here. So it's great.
And since you were just talking about working on a farm, and I'm sure kids do come along with a lot of stress sometimes. And Ingrid, you did mention that stress can be one of the major factors in aging. I know how
inflammation. I mean, it's well studied now. We're still studying about it, but it causes bad inflammatory responses. Now, good stress is fine.
Mm-hmm.
But I'm talking about the bad stress that I often see with the attorneys I work with, and it does make me a little worried.
Yeah, I
When
was going
kids
to ask
start
you.
driving, is that good or bad stress?
Well, it depends. If they're going to help you get things done, it's good. But if the bad stress is worrying about them, it's tough. It's a mixed bag.
It is
I've
definitely.
had it with two of them, and
Yeah.
You know what I've been
we all get through it. Let's just put it that way. Deep breaths.
You know what I found to be helpful is if you leave the house a little early wherever you're going and set your Google Maps to back roads. It is so much more enjoyable than getting on that interstate. But do you have any tips, Ingrid, before we go, just for any of our attorneys? Because we do know how busy they are and how many cases that they're working on. Some of
Yeah,
these
call
horrific
us and we'll
cases.
help you.
Yeah. Is there also any tips for handling stress that you'd recommend?
Well, I think exercise is number one. I think taking time off, like everybody's working so many hours a day. And sometimes I think you just need to turn off the computer and stop. Don't watch the news all the time. Try not to internalize things. There's so much good stuff in the world, and all we see is bad and stress and exercise, eating well. A lot of the yoga is wonderful. It takes some time, but I think you have to understand that your health is the most important thing. It is. And what's the use of
Absolutely.
making all this money and working so hard if you don't have your health in the end because of overdoing it? So, and call us. We will help. We will make it easier. I promise.
Absolutely. And if you guys give me just a few moments, I'll be emailing you the contact information again for Ingrid, for Jesse, and all of our amazing partners over at HMR, Fox AE, and OnPoint. Again, we were so blessed to work with such great people. Let's keep all the good things going. And again, everybody watching, thank you guys for all that you do. I think a lot of times you don't get told thank you, but I tell you, it's amazing to be a trial lawyer, to be an expert, to be a nurse, anybody in this field. Thank you guys so much because you have no idea the difference that you're making in so many people's lives. So keep it up, keep going. And we'll see you guys here again on Thursday because I have another webinar for you. We'll see you back here at 3 o'clock. Thanks again, everybody, for watching.
Thanks, everybody. Bye.
Bye, guys.